Good morning. I'd like to welcome the participants of this seminar, and my presentations will be devoted to the modern technology for AVM treatment. Let's say a few words about the epidemiology. I see the audience, and I see there are enough of people present, and I do believe some of you have an arterial aneurysm because it's a very common problem. Luckily, not all of them gonna rupture. And when we're talking about cerebral aneurysms, we're talking about saccular, microaneurysms, gigantic blister aneurysms. There could be fusiform, serpentine aneurysm, dissecting aneurysms, and the so-called de novo aneurysms that reappear after a certain treatment performed. Today we gonna talk mainly saccular aneurysms. And they're subdivided into ruptured, unruptured, and symptomatic aneurysms. That when they behave like a tumor, producing a most effect on the neighboring tissues. For a number of years of the 20th and 21st century, interesting studies have been performed to understand the behavior of the unruptured aneurysm. And it's been demonstrated that the risk factors for rupture include their size and other factors, and there's a strong correlation between the size of the aneurysm and the risk of ruptures. The aneurysms of the MCI are more prone to rupturing, and the shape of the aneurysm is also essential. If it is of a certain shape, if it's multi-lobar, it's more prone to rupturing. And the analysis of the outcome for such aneurysm is a very serious problem with a high level of mortality right after rupture. And the risk of rupture increases after a primary rupture has happened. And the risk in these cases of mortality reaches 80%. So, all the countries and the general recommendations are that aneurysms have to be surgically treated. So a patient has to be delivered to a hospital, a specialized hospital, as soon as possible to be properly treated. So such a serious pathology requires serious technologies to be involved, and today we have two main technologies. That is the clipping on the aneurysmal neck. Before certain time, it had been a gold standard, and the interventional radiology. Other technology is wrapping, proximal ligations, and so on. They went into the past because they were found dangerous for patients. As for the clipping technique that's been developing for 60 years, this technology has significantly progressed and enriched quite wonderful results with this solution. Let's see a few slides to see how it's performed. There you see the aneurysm of the anterior cerebral artery that are clipped, and you see the wonderful post-op result. Microsurgery allows you from the single approach to obliterate multiple aneurysms. And since a lot of patients have multiple aneurysms, sometimes ruptured, sometimes unruptured, and like in this case where the patient developed the so-called bilateral aneurysms that could be clipped from a single approach, and the result again wonderful. There's another example of such a case, and again, they've been obliterated from a singular approach. Another example of multiple aneurysm, so ruptured and unruptured, and there is also an aneurysm more than 2 centimeters on the eye, on the MCA, and here you see the way it looks. That's the aneurysm that ruptured, and that's the way it was clipped. And there you see the hole in the aneurysm, the plates where it ruptured. And on the other side, from another approach, another aneurysm was clipped and dissected. Clipping allows you to work with aneurysm and posterior circulations and work with gigantic aneurysms. We can use clipping even in the conditions of angiospasm. It's quite that's the case that happened quite a long time ago. That was clipping combined with a shunting technique that gave a good result. I'm not going to show how such operations are performed, but the clipping technique today that significantly changed an intraoperational angiography enable us to obtain a very high quality clipping of gigantic aneurysm, the ophthalmic aneurysms, like in the case of this patient. In its essence, this technique enables us to obtain the very good microsurgical result and operate not the brain but its vessels, like in the case of this patient, where we could obtain very good results without any post-op problems. And it's not where this technology stops in its development. We keep progressing in this respect using endoscoping technique. Personally, I haven't had a chance to use this technique, which is due to the development of endovascular approach, which is a completely new technique that enables you to use minimally invasive approach to treat a patient. This technique started in development in the 60s of the past century, and the whole world today recognized that it was invented in the Soviet Union by Professor Serbinenko, and apart from balloons used by this prominent doctor, a coilic technique came into being. First, they were steel magnetic coils. It was inconvenient, it was dangerous, but thanks to the further development of the technology, non-magnetic materials became available, and the detachable techniques appear. And today, we could we could use coils and balloons, the flow diversion techniques, which I'll talk a little bit later, because this is the technique that is constantly development and probably going to hear a lot about the capabilities of this approach. This is one of our examples. This is on the ruptured aneurysms in the ICI. We could have occluded it using clipping, but the patient preferred to have the endovascular operation, which was done without any neurological deficiency. And when we have a gigantic aneurysm of the main artery in a kid who was admitted in a very severe conditions, he developed ophthalmoplegia and regressing hemiplasia. I think no neurosurgeon would suggest clipping in such a patient, but endovascular technique worked quite well and saved this kid. So coiling is another method of choice, like in this case of a ruptured aneurysm followed by angiospasm in the primary circulation, and it was occluded. And the angiosperm was relieved. Just coiling is difficult to apply. More often it is used with balloon assistance that enable for proper aneurysm occlusion and reduce the cases of recanalization. In this particular case, stent assistant was used. This is an example of Y assistant. This is an example of X assistance that also enable us to effectively occlude the aneurysms. But aneurysms can recanalize after we perform coiling. And in this case, we could use the pipeline stent. That is a flow diverter that enable us to occlude those aneurysm. Another slide that demonstrate the efficiency of this particular approach. Flow diverters enable us to work with fusiform blister aneurysm, but as for serpentine aneurysms, there is a problem. This is the slide by René Chapeau, who delivered one of his cases in Mumbai. And here you can see a perfect angiographic result after using the pipeline stent. And such slides are preferred by Dr. Spatzler, who like to collect them and then they demonstrate what usually happens afterwards, and that what happened to this particular patient. The clinical result was very bad. So such results produce a lot of discussion. What is better, coiling or clipping? Which is this significantly reduced, and this result can be sustained for a year or so. And such results significantly change the way we do that in the countries of the US and Europe. This is the way the situation changed in the Boston Medical Center. That's here you see the number of endovascular operations increased. And if we look at the latest recommendations from Massachusetts, we can see that they suggest refusing from a CT angiography as the mapping tool in order to reduce X-ray load on a patient and come back to endovascular techniques such as a DSI, because in 67% of cases, they're switched off and vascularly. And it's turned out that after 5 years, as different randomized studies demonstrated, the results of coiling and clipping, they become comparable. But nevertheless, if we carry out the efficiency analysis based on the three different trials, surgeons prefer clipping, while for posterior circulation, endovascular treatment is better and is a method of choice. Now let's talk about the advantages of microsurgery. Adequate clipping, and as I've said, we are reaching better and better results, and this means healing of the patient. And it could provide decompression in case of the mass event and remove the hematomas and blood clots. You have to perform less procedures, remove the aneurysm, and everything is done. It requires craniotomy. Not all patients agree to be performed, and in most cases they are correct. And there are certain manipulational risks, and it requires quite a long learning curve and persistent practice in order to obtain a perfect result, like in endovascular with endovascular techniques. The factors in favor of microsurgery: this is non-ruptured saccular aneurysm, young age of the patients, and no branches are growing from the sac. And those technology have been keeping development, and we turn more to endovascular approach, since coiling is a less invasive technique, but it requires more thorough follow-up of the patient, but this technology keeps progressing. And tackling this issue, more and more doctors have come to the conclusion that it's better to have both coiling and clipping together. So a surgical team that can do both techniques can select the best the solution for particular patient. So combining this technique becomes the latest wave in the technology development. Like in this slide, where these patients suffered of the subacute hematome, and we came to the conclusion that it's better to clip the aneurysm and remove the hematome. But during the diagnostics, we found a small aneurysm on the other side that were treated using coiling. So thank you for your attention, and if you have any questions, I'll be happy to answer them.